Hello, and welcome to our evidence-based project presentation entitled Aromatherapy and the Treatment of Nausea. This project was for nursing research, nursing course 352, for the summer term 2017. Group Q consisted of Fontana, Claudia Rodriguez-Zinn, Amanda Rupp, and Alejandro Torres. For this project, the topic we explored was if the use of aromatherapy by nursing in patients experiencing nausea was alleviated and or improved. For our PICO, our population were patients experiencing nausea. Our intervention was the use of aromatherapy by nursing. C, our comparison was the use of pharmaceuticals only. Our outcome was to determine whether or not symptoms were improved or alleviated. Our stakeholders include patients, families, nurses, pharmacists, hospital administration to include managers, risk, and finance directors. Our clinical questions consist of 3 different questions. 1, if the current literature supports the use of aromatherapy to manage nausea in patients. 2, if the research supports this practice, explore existing models of healthcare where this practice has been incorporated in patient care. And 3, if supported by the research, propose an evidence-based guideline outlining the development and implementation of such a program.
The evidence-based practice model that was used to evaluate the use of aromatherapy in nauseated patients was the Johns Hopkins Nursing Evidence-Based Practice Model. This EBP model uses a problem-solving approach to clinical decision-making. The user-friendly tools of this model helps the nurse to use evidence-based tools in their everyday nursing practice. There's the 3-step process of PET, which is practice question, evidence, and translation, helps to guide the EBP process. The PET process is as follows. Number 1, the practice question. Work as a team to develop the EBP question and determine responsibilities within the team. Number 2, evidence. Search for evidence and appraise the level and quality of the evidence based on the Johns Hopkins grading criteria. You'll see this on slide 8. And 3 is translation. Create an action plan based on the best evidence-based practice. Implement, evaluate, and identify the next steps. The overall goal of the Johns Hopkins evidence-based practice model is to ensure that the latest research findings and best practices are quickly and appropriately incorporated into patient care. This pyramid illustrates the Johns Hopkins EBP model. It shows how certain internal and external factors, such as culture, environment, legislation, and standards, affect the overall model. The 3 pillars of this model are practice, education, and research. And in the center is the research and non-research criteria that guide the model. The group worked together to execute multiple ways to search for evidence regarding aromatherapy use in nauseated patients. The databases that were searched were through the California State University San Marcos Library. SynHall, PubMed, Cochrane Database of Systematic Review, and Google Scholar were used in search for evidence. The key terms that were used were aromatherapy, nausea, vomiting, complementary alternative medicine, and patient care. The selected articles included full text, clinical studies, meta-analysis, integrated literature reviews, and existing EBP guidelines. 8 research articles were found regarding the use of aromatherapy in nauseated patients. These 8 articles were included because they documented the benefits of aromatherapy for the treatment of nausea in patients. These research articles were within the last 5 years. Research articles documenting aromatherapy treatment that is not related to the treatment of nausea or vomiting were excluded. Studies that were not clear or poorly designed were also excluded. To grade the evidence reviewed, the Johns Hopkins Nursing EBP Evidence Level and Quality Guide were utilized. You can see this here. To grade the evidence level, Level 1 includes experimental studies, randomized controlled trials, and systematic reviews of controlled trials, with or without meta-analysis. Level 2 includes quasi-experimental studies, systematic reviews of controlled studies, and quasi-experiments, with or without meta-analysis. Level 3 includes non-experimental studies, systematic reviews of controlled studies, and non-experiments. To grade the quality level, high quality, consistent, generalizable results, sufficient sample size, adequate control, definite conclusion, consistent recommendations based on comprehensive literature review that includes thorough reference to scientific evidence. Good quality, reasonably consistent results, sufficient sample size, some control, fairly definitive conclusions, reasonably consistent recommendations based on fairly comprehensive literature review that includes some reference to scientific evidence. And low quality is little evidence with inconsistent results, insufficient sample size, and conclusions cannot be drawn. With that being said, these two articles were graded as evidence level 1 high quality studies. Hunt and colleagues explored aromatherapy use for post-op nausea. This was a randomized controlled trial. Joswiak and colleagues studied the use of a nurse-delivered aromatherapy program in hospitals. This was an experimental study. These two studies were graded at evidence level 1 in high quality because they included experimental studies, controlled studies, and systematic reviews that had consistent, generalizable results, definite conclusions, and recommendations. The next 6 articles were graded at evidence level 2, good quality studies. Ferrugiari and colleagues explored the effects of aromatherapy in nauseated post-op patients who are women. This was a quasi-experimental study. Hodge and colleagues studied the effectiveness of aromatherapy for post-op nausea and vomiting. This was a randomized trial. Johnson and colleagues explored the effectiveness of aromatherapy in acute care. This was a systematic review. Knutson and colleagues explored the development of an integrative health program in the hospital. This was a systematic review. Lee and Shin studied the effect of ginger essential oils in post-op nausea and vomiting. This was a quasi-experimental study. All 6 of these studies were graded at evidence level 2 and good quality because they included quasi-experiments, random trials, and systematic reviews that had reasonably consistent results and reasonably consistent recommendations. No evidence level 3 or low quality articles were included in this project.
For the synthesis of research, we use 4 categories, to determine our level 1, level 2. The first one is the level type. The second one is the total number of sources / level, the overall quality rating, and the synthesis of findings evidence that answers the EVP question. For level 1, we use 2 total number of sources. For level 1, it includes experimental study, randomized controlled trial, systematic review of RCTs with or without meta-analysis. And according to the Johns Hopkins tool, as stated above in the previous slides, these 2 sources were considered high quality rating. Some of the synthesis of findings included, findings were that aromatherapy using oil of ginger or a blend of ginger, spearmint, peppermint, and cardamom to be an effective treatment in reducing nausea severity occurring after surgery in acute care setting. To begin using aromatherapy for patients in acute care, there must be consistent nurse training, patient education, site leaders, and effective documentation. Next slide. For level 2 is considered a quasi-experimental study, systematic review of a combination of RCTs and quasi-experimental studies, or quasi-experimental studies only with or without meta-analysis. We had a total number of 6 sources at this level, and the overall quality rating of these articles were considered good. The findings demonstrate acceptance of complementary health modality is high among patients. Findings suggest the cost of aromatherapy is low, and findings suggest that patients who receive aromatherapy in conjunction to standard medical care report, on average, statistically significant decreases in pain, anxiety, and nausea.
Recommendations have been compiled and developed from utilization of the Johns Hopkins Evidence-Based Project Synthesis and Recommendation Tool. Based on the synthesis of literature, we have developed 3 recommendations. Our first recommendation is aromatherapy for postoperative nausea and vomiting should be part of the nurse-delivered nausea interventions. Our second recommendation for implementation into practice stems from each of the studies suggesting that implementation of aromatherapy as an adjunct treatment for postoperative nausea and vomiting reduces severity of pain, anxiety, and nausea. Lastly, we make the recommendation to include aromatherapy into practice from a cost savings perspective. Due to the high cost of nausea treatments in today's market, introduction of low-cost adjunct treatment coupled with a high degree of acceptance of complementary modalities by patients makes integration of aromatherapy a viable adjunct therapy. Next slide.
We would like to propose the following guidelines for nurse-delivered aromatherapy for nausea and vomiting. Background: regardless of the specialty of practice or the healthcare setting, managing nausea in patients is a universal phenomenon that can be encountered by all healthcare providers, especially nurses. According to Collins, approximately 75 million patients experience postoperative nausea and vomiting that can lead to detrimental adverse effects on recovery. Several types of pharmaceutical agents are available, but their use requires a physician's order, possible adverse effects of the medications, and cost. However, complementary and alternative medications like clinical aromatherapy show promising results and can be used as a direct nursing intervention. Aromatherapy administration. While different administration modalities are available for use with essential oils, only inhalation will be used in this guideline. Inhalation methods is relatively easy to perform and is not known to cause any adverse effects. Aromatherapy should be used as an adjunct therapy with other pharmaceutical options. There are several advantages and disadvantages to the use of nurse-delivered aromatherapy. One advantage is rapid relief of symptoms. Secondly, low cost. Third, minimal, if any, side effects to the patient. Fourth, it can be delivered painlessly with an ease of administration. And lastly, no contraindication is found with additional pharmacology. Disadvantages include possible nasal irritation and impaired effectiveness with nasal congestion. Next slide. This program would be initiated in the following format. Aromatherapy administration guidelines should be developed with the input and guidance of stakeholders. Nurses administering aromatherapy should be trained in proper selection and in administration of essential oils and have successfully passed a competency exam. Training programs will be developed and executed by a nurse certified in aromatherapy. There are 7 steps for our proposed guideline. Step 1 is identifying patients with symptoms of nausea. 2, educate that patient regarding the use of aromatherapy. 3, offer aromatherapy as an intervention. 4, if the patient accepts this intervention, administer a dose. The dose would be administered soaking a cotton ball with essential oil. 1 or 2 different formulations are available, either straight ginger essential oil or a combination blend of ginger, spearmint, peppermint, and cardamom. Administration type would be documented in the electronic medical record. Step 5, monitor patient for any adverse reactions and document. Step 6, reassess for signs of relief or continued discomfort. And if discomfort is still present, offer pharmacology. If possible, you can also re-administer aromatherapy within 30 minutes of the previous dose. Finally, program evaluation and update. Aromatherapy administration guidelines and nurse training programs should be reviewed annually. Programs should be continually substantiated by data generated from the electronic medical record, from current research presented, and should be updated accordingly.
Outcomes are based on the recommendations developed by the use of the Johns Hopkins Evidence-Based Practice Synthesis of Literature and Recommendation Tool. Patient outcomes will be documented in the electronic medical record at 30 minutes post-intervention, as will any continuing monitoring and additional interventions. Patient's nausea status will be evaluated based on the included nausea scale. Decreased cost of interventions means a reduction in hospital-related costs for the hospital and the patient. Reduced use of pharmaceutical nausea medications in patients utilize adjunct nausea interventions to be evaluated at 1 year. Patient satisfaction with adjunct therapy will be documented on the nausea scale tool located in the electronic medical record as a scale of satisfactory from 1 being very unsatisfied to 5 being very satisfied, and will be documented per patient's hospital visit. Because we are unable to present the screenshot of the tool to be used in the electronic medical records nausea scale, the qualitative Likert type scale nausea scale template has been provided in the appendix submitted with our project. Every 6 months, the method of collection of data will be generated only from electronic medical records of patients with nausea pre and post assessment documentation to ensure that continued appropriateness of aromatherapy. Next slide. Analysis will be conducted using the hypothesis testing method, answering the question, what is the effect of the intervention? A paired t-test will be used to determine the effectiveness of the hypothesis. Cronbach's alpha will be used to determine reliability of the Likert scale. Face value validity will be used with the Likert scale. Prior to use, the Likert scale will be peer evaluated to ensure applicability to the population and measurement of the proposed variable. Outcome data will be reported to stakeholders annually. Significant findings will be presented externally at conferences and professional organizational meetings where applicable in an effort to further build upon nursing interventions and body of knowledge.
And here are our references. And this concludes our presentation. Thank you very much.